So we have an incredible set of folks. We have Dr. Peter Orris, who serves as the professor and associate director of the Great Lakes Center for Occupational and Environmental Safety and Health at the University of Illinois School of Public Health. He is a World Health Organization collaborating center and director of its Occupational Health Service Institute and Global Toxics Policy Program. And he's involved in a whole range of things, including an active clinical and teaching practice, and occupational medicine, and an advisor to a whole set of groups, including the International Association of Firefighters, the International Brotherhood of Teamsters, Unite Here, it goes on, Greenpeace. Could you all give Dr. Peter Orris a hand? Welcome him. And then we have Dr. Sandra Carr-Hayes, who's a graduate of Tougaloo College. You want to clap for that. I'm listening to that. And as the executive director of the Tougaloo College Health and Wellness Center and interim program director for the Tougaloo College Institute for Biohealth and Informatics. Dr. Hayes works with national, state, and local organizations to improve health and reduce health disparities. Over the last decade, Dr. Hayes has co-authored numerous manuscripts that have explored health disparities related to the development of infectious and chronic diseases. And this time last year, actually, this is her year anniversary, which she received congressional recognition for outstanding work in health disparities. So please, Dr. Hayes, a hand. And we have Dr. Berthrone Mohammed. Did I do that right? He's a cardiologist based in Jackson, Mississippi, a product of Tougaloo College and Meharry Medical School. You need to clap twice for that. And Dr. Mohammed is not only an award-winning doctor who's written extensively, done extensive research, published, all those things. I thought on top of being the kind of doctor that he is, here in Jackson, Mississippi, he also teaches martial arts, and he's a technology entrepreneur on top of everything else. I feel like he deserves double applause for that.
Good evening, everyone. My tradition is that of Islam. We say Assalamu alaikum, that means peace be unto you. Shalom alaikum. Peace, shalom. I know we have Jewish diaspora in here. We don't? No Jewish? I know they've been in the civil rights movement. I know. We better be represented in here. All right, okay. All right. Hallelujah. Praise God. All right. And all that come with that. I'd like to thank you for being patient to come out this evening on a very hot Mississippi summer day to grace us here at Tougaloo College for the historic 50-year anniversary of Freedom Summer. As she stated before, I'm a product of Tougaloo College, a proud product of Tougaloo College and Meharry Medical College. But I remember, too, as a student here, when there was a 30-year anniversary. And we just had our 20-year. So I remember that, Sandra? Sandra and I were classmates or attending here at this time. So we have a tradition here. That's right. We got something in the back. So we actually been with you all in this period of time. So it's kind of like a homecoming back. All right. Now, I'm a cardiologist, and sure, I got a lot of slides that I can show you all. But what I want to hear more than anything is I want to hear back from you. I can show you some statistics to show you that black patients are 50% less likely to get a coronary artery bypass graft surgery, okay? 25% less likely to get pain medications when they should. And the list goes on and on and on concerning all the disparities. However, beyond any study that is published, there's also the back chatter of what really is going on. What is the study really telling us? Is it truly a racial disparity relating to racial prejudices or biases that come into play that make doctors and nurses do things that they should not do with certain patients? Okay, that really is the question. Okay? Now I know my colleagues that are setting up for their slides, they're gonna have a lot of data, and I wanna look back and see what they have as well, so we can interject some more if we need to give you some more. But I'm gonna start with a patient scenario. The reason why I'm late today here is I just actually experienced the health disparity related issue. Let me paint to you an issue. I just left a very sweet woman. She's about 78 years old. She's from Mexico. She speaks no English. We had to get an interpreter on the line to deal with the aspect of her having chest pain. Now keep in mind, she came in with a heart attack. Imagine the language barrier that exists between the doctor and the patient. I'm trying to help you. You don't understand what I'm trying to help you at, and there's fear that comes into play. So, many times, there may be a scenario where the doctor feels that it's too much work. You know, I've done my due diligence. I tried, get an interpreter, and the patient may have a heart attack and die later. But they did at least technically the right thing that they did. They saw the patient. They prescribed the medication. But I went the extra step of making sure that I stayed and made sure she really understood what I was asking her to do. And her family was there, but they actually did not, have a good command of English. So we went through the scenario of what the procedure is about, what we're going to do, how we're going to do it. And she started to light up. And her daughter started to cry. I was asking why she's crying. I said, well, you're the first doctor that has come in a room that has spent that much time actually trying to see what's going on. And I said, well, that's what we're supposed to do. I mean, unfortunately, I can't do it all the time, but I do it as much as I can. She said, well, come to find out, you just listened to her. It may have been gas or some other thing that was very simple, but it could have been something very serious. But sometimes when we look at things from afar, such as committees in a hospital, and kind of dancing around a little bit, giving you a kind of a primer of where I hope questions would come out from the audience from. And we're in an esteemed presence of Dr. Robert Smith in the back, emeritus as well, physician in his own right, legendary pioneer who practiced medicine here in the state of Mississippi, and one of the ones I follow in his trail master ass. But he's there in the back. Dr. Smith, can you raise your hand? Very good. But we are often the victim of what only our eyes can see. And so when you look at what these studies are put together on, they base it upon the fact that, number one, there's an outcome that you're measuring. Okay, the outcome is either death, heart attack, event, cancer diagnosis, etc. You've heard about the VA in the news. Some outcome that occurred that was bad. Now we're going back trying to figure out, well, what could have prevented it, or what scenarios caused the outcome to occur? And there are multiple. So when you're looking at the scenario, it doesn't take into play the human content of what these particular studies are put together. It only tells you the result, and you're left to decide what you think is going on. Okay. So I caution you to kind of say, okay, what's behind the actual studies and what really is it saying? Okay. Now, there's one particular study that I'll tell you about, and I'll just tell you about it without showing you slides on it. If we need to show you slides, we'll show you slides on it. But there was a particular study that intrigued me that was placed and published in the New England Journal of Medicine in 1999 by Dr. Schulman. Okay? It involved 720 physicians. And these 720 physicians actually recorded a hypothetical patient. They put together a scenario, put these various patient scenarios on record, and they decided, how will you care for this particular patient? Based upon this particular analysis, they were able to find that there were significant differences in how various doctors led toward medical decisions. For example, black women who happened to be patients in the study were significantly less likely to be referred for cardiac catheterization than white men. Odd ratio of 0.4. Okay? Women and blacks were less likely to be referred for cardiac catheterization than men and whites, respectively. Now, I'm going to pause right there because I'm not going to give you a lot of data because you're going to hear a lot of things, but I'm going to also point the human factor in. I'm an electrical EP cardiologist. What that means in short is I'm an electrical doctor. I put in devices, pacemakers, defibrillators, things of that sort. One of the things that I'm often asked by a lot of my female patients is this going to disfigure me? Is this going to disfigure me? I mean, I don't want to have a scar on my chest and it be disfiguring, and I want to make sure my body is not disfigured. But death is a very ugly thing. It really doesn't care how you look. Really don't. This is the church now, y'all. Y'all can just get on. Does death care how you look? Does it care what color you are? Does it care what sex you are? Does it care how much money you got? It really don't care. It can hit you anywhere. And unfortunately, sometimes decisions and what we think about ourselves also impacts how we respond to someone telling you something that could potentially save your life. So, not to say that that's what happened, but I want you to challenge yourself. Sometimes simple studies don't always look at the human aspect of what is really going on behind the scene. And so if you explain more, if you take a little extra time, the doctor takes a little extra time on the other side to explain what this is about, and maybe the physician or the patient, taking an aspect to understand it herself, then maybe you may come to some agreement and may have a different outcome. But there are a lot of other things that come in play. Now, how much time do I have and how much time have I been speaking? Okay, all right. Okay, and we're not taking questions today, we're moving straight on. Okay, all right. Okay. So, a couple other things. There are many other studies that have been shown and cited by various groups. The Association of Black Cardiologists have a website, and they have inundated amount of information that talks about healthcare disparities and overcomes, and talks about culturally congruent healthcare, which is a new term that you may hear. How many of you have heard of that? Culturally congruent healthcare. See people in the back? Good, good. So it means being sensitive to the aspects of culture, nuances that you may not always think about when you're entering into the hospital, or better yet, caring for a patient in the hospital. For example, let me challenge the audience with some things. I think we got to get everybody woke up. It's hot. You got to get you animated. I know you're trying to save your energy. I got it. How many diabetics do we have here? Okay, diabetic. Okay, diabetic. All right. If you're a diabetic, of the diabetics, let me take a random poll. How many of those two diabetics, you only got a number of two? Just take a guess. Is anyone a Muslim? No. Okay, all right. If you happen to be a Muslim, which particular diabetic medication contains pork? Would somebody say so? Who said it? Yep, there's specific insulin, okay? But insulin, regular insulin, contains pork. Comes from the pork animal. So if you see someone saying, I don't want insulin, I don't want insulin, I don't want that, I don't want that, you need to ask the question of why you're not wanting that. Where's that coming from? There are other choices now. You have synthetic insulin and other analogs that you can treat with, but if you did not engage that particular patient to understand those things, you can have a barrier set up. And the key is overcoming those barriers so that we can deliver better health care, culturally congruent health care. Okay, other nuances. Any Vietnamese here? Okay, all right. Anyone ever heard of cupping? Cupping. Okay, all right, cupping. Cupping is a practice in the Far East where you put suckling aspects on the back and the chest in order to kind of, as a healing aspect, particularly people with lung disease, but it helps to open up and rid it of toxins or so. These configuring marks on the back. But if you look at it, it looks like somebody's abusing someone. But if you didn't know, it's actually an ancient method of treatment. Actually, we use it in boundary medicine too. But again, misunderstandings will cause you to think otherwise, that, hey, something else is going on. So key thing is health disparities and chronic diseases go hand in hand. But we need to be at the aspect, instead of condemning and reaching quick conclusions, that we look behind and pull off the rafter to see what exactly is at play. One final comment relating to a real patient scenario, relating to health disparities. I can't leave you without stating the fact that access to health care is a major problem. Okay, I can't stress that enough. I can't stress it enough to the fact of acknowledging the fact that without healthcare access, you can't treat the patient, you can't diagnose the patient, okay, and you can't continue aspects of preventing death and other aspects that come with these diseases. So, we just experienced a period where we had enrollment with Affordable Health Care Act, right? Okay. I'm a practicing doctor in the community, cardiologist. Wouldn't you know, I'm seeing a significant number of patients that have not enrolled in that. at this time. You all have heard about it, right? You all have heard about it, right? How many of you all are enrolled in Affordable Health Care Act? How many of you all enrolled in it? Good, good, good. One enrolled in it. The rates are great, y'all. I'm not selling it here, but the rates are great. I wish that was mine. The rates are great. What I'm getting to say to you is that even to this day, patients are presented to the emergency department without insurance. Now, you have a patient that doesn't have insurance, having a very serious problem. We have what is called unreferred care tracts, where a hospital can mandate a doctor to see a patient even without getting paid, and say that that patient is cared for during the period of time of that hospital stay. Now, you ought to say, well, hey, he should pay for it, right? And they should do it. He's not getting paid. Doctors are rich, right? Right? You don't have to. I'm listening to your consciousness. Don't worry. I know. The common premise is that they're rich. You got some that are, some that are not, and some that are really, really struggling. But when that patient is seen, all the biases that go into the fact of saying, how are you going to care for that patient, comes out in play. There's no way to refute it because of the fact you're looking at how can I minimally reduce resources and treat this patient. That's a health disparity. Clearly right at the point, but it starts at access to healthcare. But all of the aspects of what you see as a result, the effect of it, comes about because of the fact that that's how it started. Now, I can flip the coin the other way. People who have insurance, good insurance, okay, refuse to see the doctor. Refuse to take ownership of chronic problems like diabetes, okay, cardiovascular disease. 2 minutes, okay. And so by virtue of that, they make decisions that don't impact them having better outcomes because they don't take medications, they don't see their doctors. But now, the current play is that doctors are under a lot of heat these days. A lot of heat to basically be responsible for the outcomes of that patient. So that means you become the coach, the preacher, the teacher, the healer, to get them back on track. But eventually it's going to come circle that we all have to be accountable for ourselves first, and as a community collectively, because that's the only time and way that these outcomes are going to be changed. Okay? So I'm going to pause there. I hope you got some sense of, at least from a realistic standpoint, out of the community, what we see, and hopefully you're going to be looking at some other data and supporting data by which of that. But I thank you for being patient and listening to me. Hopefully we can get into some discussion later about these issues. Thank you so very much.
So next up we have Dr. Hayes. Thank you.
Well, good evening again. I'm Sandra Hayes, Executive Director of the Health and Wellness Center here at Tougaloo College, and as Dr. Muhammad indicated, we are classmates, and he chose medicine, the one-on-one route. I chose public health. I'm an epidemiologist by training. However, in thinking about this topic, thinking about Freedom Summer, what it means today, and what it meant 50 years ago, I had to think about, when we talk about chronic disease health disparities, how can I link what happened 50 years ago to what is happening today? And one of the things, as was indicated in the introductions, it's about identifying the problems, but also coming with solutions. So today what I wanted to talk about is chronic health disparities, but I want to talk about it from the perspective of the historically black college and university, because we actually are a cornerstone in many black communities, and I think that it's important that we know what our role is and we actually take ownership of some of the solutions that need to be presented. Next slide. So what I'll be talking about today are chronic health disease disparities that are affecting black Americans, and I'm not going to show you a lot of numbers because I know you've seen the numbers. Identify some of the reasons for health disparities, and then also discuss the role of historically black colleges and universities in addressing those disparities. So here we have a picture of President Obama, and what I want to bring to your attention is the quote that he stated during one of his press conferences where he said, "In America, we share a dream that lies at the heart of our founding, that no matter who you are, no matter what you look like, no matter how modest your beginnings or the circumstances of your birth, you can make it if you try." Yet for many, and for much of our nation's history, that dream has gone unfulfilled. And we clearly see that when we look at health and the health disparities that exist today. So to kind of put us in the context of what I want to speak about, a lot of people saw 50 years ago veterans walking and speaking about voting rights, but what they did not know, and many people don't know, is there was also a health component during that time as well. So we look at an unequal system of health in 1964, and particularly in Mississippi, where those disparities were quite rampant as they are today. So just to kind of put you in context, 50 years ago, more than 100 physicians, students, psychologists, and other health professionals from the North came here to Mississippi. And they were deployed by an entity known as the Medical Committee for Freedom Summer. They established health information and prenatal programs, and they also noted the dire consequences, the dire situation of the residents here in Mississippi during that time. And during that time, they strove to provide a more equal system of health for Mississippians, and they began to advocate. And one of the things that we note now is that, if you go to the next slide, 50 years later, we're still in that same dire strait. So just to give you a little bit of a background about our demographics here in the United States, blacks make up about 39 million, there are estimated to be 39 million blacks living in the United States today. And I'm saying blacks instead of African Americans because I think it's important to note that the black lineage encompasses several different things, not just Africa. We also have West Indies, Caribbean. So when we look at brown people, dark-skinned people, we're looking at not just Africans. So when we say African Americans, we're just identifying one geographical location, but it is encompassed by many. And so now we'll move into a little bit of the discussion about obesity, about health disparities. We do know that when we look at disparities related to obesity, black adults have the largest, and we're also, when we look at childhood obesity, the trend is the same. And in 2010, we found that the prevalence of diabetes among black adults was nearly twice that for white adults. Next slide. We know that black Americans have the largest number of deaths due to heart disease and stroke when compared to other racial and ethnic groups. And more black Americans suffer from hypertension. We also know that the percentages of black Americans who control their hypertension is lower when compared to other groups. So here are just the 10 leading causes of death for black Americans. And if you look at that, you'll note that 4 of them are related to chronic diseases. So 40% of our leading causes of death can be attributed to chronic diseases, which I'm also going to add are preventable if you're living an appropriate lifestyle. Next slide. Okay. So let's talk about what health disparities are. How many people actually know when we say health disparities, what a health disparity is? So according to the Centers for Disease Control, a health disparity negatively affects a group of people who have systematically experienced greater social or economic obstacles to health. And I put that definition there because just because I'm black doesn't mean my health will be different. There are other factors that contribute to that, and some of those factors are preventable. Now, race, genetics does play a role in health, but when we look at the definition of a disparity, we're talking about something that causes you to have poorer health that may not be necessarily in your control. Next slide. So we talk about social determinants of health, and they can be categorized in a number of different ways. There are social determinants. Dr. Muhammad talked about insurance status, whether or not you have access to care, whether or not you can utilize these services, how far you've gotten in college, your gender, is food available, Do you have housing? They can also be behavioral. Do you work out? Are you physically active? What are your eating patterns? Do you use illegal drugs or drink too much alcohol? Next slide. Environmental determinants. I mean, is your environment conducive to good health? Does your house have lead in it? What kind of working conditions are you living in? And then, of course, the biological and genetics. What does your family history look like? That can also determine your health. Next slide. So then we move into another important definition, health equity. So we talked about what a health disparity is, but there's also another definition that I think we need to talk about when we look for solutions, and that's health equity. What is health equity? Health equity is the ability to attain your full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. So the fact that you do not have money does not mean that you don't have access to care. Health equity. Even if the resource is there, is it available to you? Next slide. So when we talk about these definitions, health equity, health disparities, we want to begin to look at some of the things that HBCUs have done in the past, as well as what we need to do in the future. I'm going to use my presentation more as a call to action, because I think when we convene like this is more of what we're looking at. So just to tell, a lot of people say HBCU, but what is an HBCU? So there is a definition. So in 1965, an HBCU was defined as any historically black college or university that was established prior to 1964, whose principal mission was and is the education of black Americans, and that is accredited by a nationally recognized accrediting agency or association making reasonable progress towards accreditation. So that is what an HBCU is. Next slide. And the first HBCU was founded in 1837, and as of 2007, we had 105 HBCUs in the United States. And most of these HBCUs, you're at Tougaloo College, are located in areas of high poverty. Even if you go to Morehouse and Spelman's, they're in areas, Clark, Atlanta, they're in areas of high poverty. And in these communities, HBCUs are more than just places that you get an education. They're also places that serve as anchors for that community. A lot of people come here to use our clinic, use our fitness center. We don't just educate, we're also a community resource. So when we look at the importance of HBCUs in the black community, several public and private HBCUs are state and national leaders in the production of black American physicians, nurse practitioners, and public health professionals. And HBCU graduates make up more than 20% of the nation's African American degree holders. 7 HBCUs, and they're located in Texas, Louisiana, Mississippi, Tennessee, and South Carolina, have focused on health disparities, and some of them are evidenced by having centers of excellence in health disparities. Next slide. So, how do HBCUs need to act within the community, and how do they need to engage the community? Michael Lomax said that for historically black colleges and universities, engagement is not an enhancement of their curriculum, but part of their birthright that can be found at every level of the economy and society. The fact that Tougaloo College actually has a health and wellness community resource center speaks to that. Not every college that you go on is going to have a community health center that has all of these resources available. So this is by our mere existence, one of the reasons that we exist, to be a resource. And here are some examples of how HBCUs have engaged the community. Xavier has based its community engagement on its academic specialty, which is pharmacy. 2% of the nation's 6,000 pharmacists come from Xavier. And it's also one of the top producers of black medical school students. Okay, so being at the forefront of our public health research, we have many partnerships. And I can tell you that I partner with the CDC, the NIH, the Office of Health Disparities, the local health department, community organizations. We work through partnership with each of these entities. And another example would be Hampton University, who just received a $13.5 million grant from NIH to do a health disparities research campaign on men's health. And this initiative brings together 6 HBCUs to study things like prostate cancer, cardiovascular disease, obesity, and other issues affecting men. So we have another issue that I think we need to look at when we look at the importance of HBCUs in the community. And that is the existence of HBCUs ensures to a certain degree that we have a small amount, still not enough, of diversity in healthcare. Because the example that Dr. Muhammad shows is that many patients want to speak to someone that looks like them. They understand where they're coming from. They can explain things. In his example, it was a language barrier. But sometimes there is a language barrier and we are both speaking the same language. So the diversity in healthcare is essential. Racial and ethnic minorities are very underrepresented in health professions, and that is extremely important when you think about the fact that we represent 13.1% of the population, but it's not reflected in the health professions, in the health professions workforce. And here are some numbers for you. In dentistry, black professionals make up 3.3% of the dental workforce. In medicine, we have 4.4% of black Americans making up the medical workforce, 8.8% in nursing, and 5.1% in pharmacy. And the percentage of students enrolled in health professionals training is 5.4% in dentistry, 7.4% in medicine, 11.8% in nursing, and 9.3% in pharmacy. So we make up 13.1% of the population, but that's not represented in the workforce, in the health professions workforce. So, why do we care about whether or not we have a diverse population of healthcare professionals? Well, first of all, when we talk about cultural congruency, we need to have a population of healthcare professionals that understand different populations that they're working with. And it improves the access to healthcare to have a culturally competent workforce. Patients have greater choice, and they also exhibit better satisfaction with their healthcare professional when they deal with health professionals that look like them, or at least a professional that can understand them. So even if you don't look like your patient, you need to have the tools to be able to interact with the patient. And then as far as students going through the healthcare professions programs, they also have better, they claim to have better experiences going through their programs, especially if they're going through maybe a historically black college or university. So racial and ethnic minority patients who have a choice are more likely to select healthcare professionals that look like them. They're also more satisfied with their care, and they also tend to adhere to their treatment plans a little bit better because, with the example that Dr. Muhammad showed, if you're treating a Muslim patient and you're trying to give them insulin that they think has pork in it, I don't think they're going to adhere to their treatment plan very well. So also having diversity means that you have a workforce that has a more broadened perspective of differences in race and culture. And you also have more of an ability to empathize with your patients. You can relate to different things if you have a more diverse background. So here's the call to action. We know that HBCUs are well positioned to address, and you can go to the next slide. Next one. Okay. So they're well positioned to address disparities for several reasons. I went through Tougaloo College, and the program was pretty rigorous when I went through it. Despite what some of the reports are, HBCUs have very rigorous programs. The tuitions tend to be more affordable. Now, in the case of Tougaloo, we're private, but even with this, for the state institutions, they are more affordable. You also have that small college experience. Everyone knows everyone on campus. Is more likely that you'll help your classmates if you know them. You're not in a room with 50 other people. It's more one-on-one. And then, of course, the cultural sensitivity. HBCUs tend to accept people who generally may need a little bit more help. They may come from different backgrounds. They may need to be taken to another level before they're actually let go into the workforce. Next slide. So what do we need to do? What am I asking for? A couple of things that we need to do when we think about engaging HBCUs in this fight to reduce or eliminate health disparities is we need to increase our infrastructure. We need to build the capacity to function as more vibrant enterprises. Yes, we're small, we're family oriented, but we're also businesses, and we need to begin to think in that mode. We need to understand that we're in the business of educating people, and we need to begin to act like that. The curriculum also needs to reflect what we need to know when we get out into the world. We always talk about the world, what the world needs to do for us. But we also, when we're on this campus or on these campuses, the curriculum needs to be global in perspective. That curriculum needs to portray more than just our experience. It also needs to be a two or bi-directional learning. We need to learn about the world as well, and that curriculum needs to reflect that. And then research and discovery. Who better to give the answers to some of the most pressing questions that we have today than other minority researchers? They have more of interest in what is going on, and really they have a vested interest in solving some of the issues that are affecting Black communities today, or minority communities. So one thing I'd like to leave with you as I begin to close is that we are relevant and we are necessary for healthcare reform. Historically, Black colleges and universities have played a vital role in the nation since their inception. And some of the most famous individuals that have left such a big impression on the world have come from HBCUs. Dr. Martin Luther King graduated from Morehouse College. Dr. Marian Wright Edelman, who's actually on our program for this event, graduated from Spelman College. Dr. David Satcher, Surgeon General, Healthy People 220, Mr. Healthy People 2010, came from Morehouse College. And Tougaloo's own Congressman Benny Thompson, who fights on a day-to-day basis to try to eliminate or reduce health disparities, came from Tougaloo College. Next slide. So what do we need to do? We need to be engaged because we are relevant. The next cures can be at an HBC, can be found at an HBCU. The advocates for quality and affordable health care can be found at an HBCU. The next design for healthier communities can be found at an HBCU. The work that needs to be done to remove those social determinants that result in poor health outcomes, that researcher can be found at an HBCU. And so as I leave you, I just want to ask the question that several people have asked before. When is the right time? If it's not now, when? And if it's not us, who is supposed to do it? And I submit to you that we are supposed to do it. These health disparities that affect African American or Black communities, the answers can be found at HBCUs. We just need to use the tools that we've been given so that we can do that.
Colleagues, Dr. Mohammed and Dr. Hayes have now taken half of my slides. Since I always bring too many anyway, that's going to be great. We'll shorten it up. One of the things that has been talked about without the numbers, and this is just purely one selected aspect, and that is the differential treatment rates and treatment of African Americans specifically, or more specifically African Americans making a few stops on the way here in the Caribbean and other locations, and the differential between white Americans, also a polyglot of groups, and this is just one indication of different therapies for the same kind of disease, and this is one voice preservation therapy for somebody with laryngeal cancer, and there are many more of these. I want to stress two things about all of those slides that we've skipped over, and these slides as well. We are talking here about an institutionalization of racism not being fully addressed by this country. It is not the individual practice of one individual physician that solves this problem. It is the institutional racism that places minorities and economic impoverished people within the country at far greater risk of developing these chronic diseases, because it is the structural position that people live in that increases your risks for these diseases. Yes, it is certainly exacerbated by individual behaviors. And yes, you can modify it to some degree by individual behaviors. But when we are looking here about a society as a whole, and the effect on a population as a whole, we have to look at what environments people are living in and how those environments impact on their health in comparison with the health of the population as a whole. And by looking at that, you cannot avoid the assessment that both these health disparities, and I too don't like that word particularly, because I think that word has been chosen to avoid the confrontational language of a structural racist society that we still live in which you place a whole section of the population, primarily African Americans, but as well other minorities, at much higher risks of these preventable chronic diseases. And having said that, when you have them placed at a much higher risk and developing these chronic diseases at a higher risk, you would think that a healthcare system that was a true healthcare system, in other words, a system directed toward assuring or restoring health to a population, would direct the majority of their emphasis and expenses at the population that the epidemiologists tell us are most at risk and are suffering the most from these conditions. But what we discover in looking at the US healthcare system, which used to be a novel experiment in the world's situation, but unfortunately is not quite so novel anymore as some of other countries have mimicked this development. We look at a system that we don't have time today to discuss, but over 150 years has perfected this system as, in fact, a system that is primarily designed to make a profit from illness and bring people back to some semblance of health. But when they're healthy, you don't make a profit. So they get sick again, then they come into your system. And I spent 40 years at County Hospital in Chicago doing general internal medicine. I do occupational environmental medicine, and I'm at the University of Illinois. And I tell you that people come back and come back again because of going back into a community and going back into a living environment that generates and stimulates these diseases. And with purely medical care, we direct our primary expenses at those populations that can afford to pay us more and more every year. Now, I want to add, especially with some of my colleagues from the Service Employees Union here and the Doctors Council, that the situation with physicians and the attitude about physicians all being wealthy is beginning to change, because the physician's relationship to this system is changing. No longer are physicians securely private practitioners make all they can make from a system. And certainly not all physicians do. There's the old phrase as well, my doctor's a saint, but doctors in general are crooks. Both of which is probably true. But having said that, physicians more and more now will be operating under standard protocols, working for larger and larger institutions, and unfortunately still working for institutions that are primarily directed for the income that they can take out of the patient from their insurance company, etc. We do not have a way as yet, and we may be getting to it, and that's the end of where I'm going, and that is with the ACA and where that is on the stony road we trod or whatever, but we do not have a system yet, and the ACA does not take us there, in which the social costs of disease, which weigh on us all, the social cost of disease is in fact made to impact on the process of medical care, so that the system of providing medical care does not get primarily rewarded for making people well so they get sick again, but primarily for keeping them healthy. The only way of doing that and taking those social costs and shifting them so that the medical care system has those same risks, despite everything we are trying to do with the ACA about tinkering around the edges of those while leaving the insurance companies alone and leaving the hospitals alone. The only clear and simple way to do that is a governmentally directed system, which we call single payer, which is not foreign. The Canadians, who are everything like us, except they live across the border and are slightly more civilized than we are, certainly. The Canadians have done it for a long time, and it works. Is it the solution totally? No, there is no solution totally. Any of these systems need to be followed, watched, and they need to be advocated within, and the people using them need to have controls over how they're using it. So having said that, let's just see where we're at now. Next. The widening income gap in the country is, of course, one of the aspects that's a problem here. But no, keep on going through. I want to get to keep going. And the immigrants are worse off than others. Keep going. I just did that. Okay, here we are. What are the important reforms of the ACA? Okay, the ACA basically has spread coverage. And not only have they spread coverage by making a lot more people eligible, but in removing the prior condition problem that allowed more people in, and putting students on until they were 25. In other words, there are all of these aspects, primarily the spread coverage, very important. And despite the day-to-day fight against this, as you know, they were quite successful in signing people up. Yet, next slide. And with that spread coverage, that we expect to see a change in this continually increasing curve of Americans without health care coverage. And we expect to see a drop, maybe not as much as this. We are already seeing a drop in this trend. This doesn't mean that everybody's getting covered. Next slide, please. It will not cover everyone. Next slide, please. In fact, these states have not even expanded their Medicaid, and their Medicaid expansion was such a gift from the federal government that this is an extraordinary ideological commitment over economic, and we will hope political retribution that hopefully will follow in the leadership in those states that have not yet done it. And we expect in the next year or so that many of these states will now fall over, seeing this working, seeing it successful in the other states. And so this expansion of coverage will continue and needs our help strongly. And in the next year, in states like Mississippi that have increased their participation, but have not increased the eligibility. We expect to see that struggle going on throughout the country. Next. Next. And this is more of the same. But when we get all through with that, even if everybody expands Medicaid, we've still got 4.8 million adults without coverage. Much better than 48 million today, but still 4.8 million more than we should have, and not counting adults and children without the paperwork to say why they're here, who have been cut out of the system completely. Next slide, please. So we're doing pretty well. Next slide. Most of us are not affected by ACA. We may be affected by ACA in the next several years in terms of the competition in the marketplace, which we're looking forward to, bringing down some of these rates. Next slide. We know, Mississippi notwithstanding, because we were told yesterday that the recruitment to the ACA in Mississippi has been heavily African American. But notwithstanding that, in other states we have had considerable problems where you only reach 40% nationwide, and in fact, people of color in general, just 30%. Next slide. Next slide. So the big problem that we have and where we move ahead and how we must look to strengthen the ACA is this real problem of deductibles. Because so much of the insurance, especially that the young people are buying today, it's insurance in name only almost. And I'm really amazed that as many healthy young people have bought it. Because when you look at the deductibles in those rates, most of the year and most of their health care is going to be out of pocket in a lot of these plans. Next slide, and I think I'm done. Underinsurance is becoming the norm. Next slide. We have the data to know that underinsurance causes people to skip needed medical care and have problems paying medical care. Next slide. We know that there are differences in care for any number of chronic conditions. This is just diabetes and the sequelae. We started with diabetes, Dr. Mohammed. The sequelae, we know that the complications of diabetes, if you don't have adequate insurance, you develop more complications. Next slide, please. And this is true absolutely for asthma, one of our major problems in the cities and throughout the country, and has a definite racial and definite economic differential from. Next slide, please. Yet at the same time, we still have a system that is buying unnecessary procedures, where people are doing procedures that are unnecessary and are wasting money, and a system, next slide, in which the number of administrators is going through the roof. Why? Because the system still allows the private insurance companies. And as a hospital, I have to hire a bunch of people to figure out how to build the insurance companies to my maximum limit, or I'm going out of business. And as an insurance company that makes its money from the stock market, I have to figure out how to hold that money for 1, 2, 3 a month more. And the way I hold it is to find something wrong with what they're sending me, so I can send it back to them, and I don't have to pay them for a month. And if I find that, I need a whole pile of people looking for that. The system here is just clear generating this. This is not an individual decision. Next slide, please. And I think next slide, and I think we're done. Next slide, I already did. All right, I'm done. My slides, I apologize, as always, are too many. I appreciate the chance to bat at the end, and I really thank you for allowing me to talk about this today. Thanks.
I want to thank all of our panelists again. I think they deserve a round of applause for their preparation.
I just wanted to say, tomorrow is National HIV Testing Day, and I would love for people to get tested. You can get tested here on campus free, and it's 15 minutes. That's all I had to say.
I'm not a health professional, but coming back to Mississippi and walking around the neighborhoods where I lived and worked, one of the big things I noticed is that there aren't any gardens. I learned to eat vegetables in Mississippi. I never ate collards before I came here. I never ate a lot of okra before I came here. I never had fresh eggs out of the backyard before I came here. And in Meridian, the town where I lived and worked, I walk around there now. I've been walking around for the last week, and well, actually the last 2 or 3 years. And there are no gardens. And I guess I just wonder where that is in the debate and the process. I just wonder if there's people thinking about bringing back gardens, or what you think about that.
That's an excellent point. I would just simply remind everybody, it's a little biblical, the herbage was provided for us. We veered off into meat after Genesis. So really, it's not enough even to say more on the fact that a vegetable diet, fortified in the right manner, with essential oils, really is a blissful diet to have. In fact, Mediterranean diet is what is a cardiology heart diet that we allude to, that contains a lot of vegetables along the side, parsley, garlic, green leafy vegetables, fish items, whether it's anchovies, salmon, tuna, mackerel, things like that, that has the omega-3 fatty acids in it. But essential gardening organically in itself, it's starting to be really a new thing that's being taken on, I think, by the community at large. Tougaloo does have a garden, and a community garden. And they invite us right in the back toward the rear. They also have one inside of the city as well. But they have a community garden club. And actually, they allow you to bring your seeds, or they give you seeds, and then you can put them in the ground, plant them, and come back and harvest them. They really extend this out to children. So it's starting to be a really cool thing, as some of the kids are saying. So it is definitely helpful.
Just to add on, yes, we do have a community garden here, and actually that seems to be a trend. I know the Kellogg Foundation and several other funders are now looking at initiatives that bring community gardens back so that we can teach young people how to grow their own food, and actually not just in rural areas. Now some initiatives are looking at how do you grow gardens in urban settings. So people do recognize the importance of eating more vegetables and how that is impacting or influencing the development of chronic diseases. And so the USDA and several other foundations are looking at community garden initiatives.
I work with a group called Healthcare Without Harm. This is a group that is primarily interested in the environment and interested in sustainable healthcare in general. But we work on the assumption that and the understanding that when physicians and nurses stopped smoking in this country, it had a major impact on the population as a whole. And when the healthcare sector, which is such a large sector in the U.S., begins to change its behavior because of environmental issues, that will have a major impact on society and will also be very important because of the size of the sector. So we have been raising over the last 4 or 5 years now the question of healthy foods in hospitals, because as you know, there was a great trend in the 60s and 70s for McDonald's to open up at children's hospitals, etc. The best way to keep the other kids quiet while you were going there for one kid was to give them this high-fat food, etc., which they wouldn't have an argument about staying, etc. So today now we are making important progress with respect to the major national networks of hospitals in substituting healthy diets, both for the patients and for visitors in those settings. And we expect that to spread because, as we said, there's a lot of foundation interest, and in general, people are looking at it, and certainly in healthcare are looking at it and saying, oh, of course, why don't we know why we have heart disease, why are we modeling that behavior? So we're very excited about that development, and Vermont is certainly a place where it's going on as well.
We have a lot of limitations. We are primarily limited by the food that we bring in. We do a lot of nutrition education, but that doesn't make a difference if we are just getting sort of leftovers of this company or that program or that sort of thing. I'm sorry. So we're really trying to explore where we can have the most impact on health disparities, especially around nutrition education. I'm just wondering where you as health professionals see those opportunities to partner with community organizations to have the greatest impact.
Well, one partnership that you may want to look at is schools, because one of the things we do know is that if you start with good habits early, you tend to take them over into adults. So I would look for partnerships in schools and making sure that schools serve healthy food. But the other thing we know is that you can start at school, but whatever partnerships you have need to also include the parents. Because if the kids are eating healthy and they're going home and eating junk, then you're kind of not getting the full scope of who you could reach. Also, I think maybe faith-based organizations, and you also, institutions of higher learning may be another way that you can partner. Also, some community organizations, grassroots community organizations may be some good places to do some partnerships.
May I make a comment on that question of the gardens? I think people are just lazy. I think people don't want to go out. It's like taking children out for recess. I just think it stopped because teachers don't want to go out into the hot air. I think we give away too much food, and I participate. My church has 2 food banks, and I went and I did a survey, and I looked at all the food. I said, number one, there's too many canned goods up in here with this high salt. If we give children at our after-school daycare nothing but cookies and sweets and junk, I said, they didn't want me to come back. But I just think we've gotten too lazy. We're giving away too much food. And the second thing is part of that economic picture. Many people in Hattiesburg, and I'm specifically talking about Hattiesburg, where the hospital industry is very big, Forest General and Wesley, they work 12 hours. So they have to be at work at 6:30 in the morning. That's why so many children are ending up at those morning breakfasts and lunch, and then they go to we pick them up in buses and take them to after school and give them garbage.
I think part of what we got to hear today was more not only about the things that we see that are like these sort of portrait pictures, but what are the larger contexts that drive those behaviors and how we come to understand it. And even things like gardens and what happens in laws and land use and planning, and in many communities they're struggling even, right, to even figure out how they garden. Communities where people used to keep chickens if it's against the law, like all those things. So part of what we're doing here is moving between what we see and how we come to understand it, and then the histories and that's what this is all about, right? So I want to give our panelists maybe a couple of minutes each. If there's any other thoughts you want to share with us before we close.
What I want to give with is that empower you for one thing. From a physician standpoint, on the front lines, is that when you get out of here, if you don't take anything from anything of what we stated, you got to get active and involved, both first personally to understand if you yourself have an illness, own it. Okay? If you don't own it and address it, or so, it will keep on defeating you. Okay? When you enter the hospital, ask questions. If it's something you don't understand, and they're not talking English to you, say, look, can you explain that a little better? I don't understand. Okay? Simple words like that will get wealth of information that you can get, and it will break down barriers. Okay? Some other aspects. Health and diet. I'll just give you a point on it. Talk about the struggle of eating right. Having to be a part of a civic organization, Fraternity Phi Beta Sigma Incorporated. I know she's AKA, because we're going over at the same time during that period of time. But we're civic organizations, and one other organization we're part of. is Masonic organization, Freemasons. And we have various great events that we have throughout the year. And one of the fastest way to get to the hospital is what you eat out of some of those events. Okay, how many of you all know? I know that those who have come up to talk about collard greens. What is hog maws? Oh, don't act like you don't know what that is. We know what that is. What is it? What is it? Could you stand up and tell us? What is it? It's the stomach of the cow. Okay, all right. What about, but also the pig too? Large intestine. And what are chitlins? Chitlins are the waste product that it goes through that too. That has been made a delicacy. Okay. Now I'm going to just go there because we have intelligent people here in the audience, and this is not the audience I'm worried about out there in the community. You are the ambassadors. Okay. But I call that type of diet a slave diet. A slave diet, both whether you're white or black, it's a slave diet. The reality of which is that diet occurred because of a practice of slavery that all in the room can admit occurred, where the scraps of an animal were laid out for those slaves. They used onions and other herbage to create a certain type of taste to it that made it palatable. It became soul food. This same soul food is killing us. Okay? There's when I was at Tougaloo College, my term paper was on the salt gene hypothesis in black patients that developed them to develop hypertension. Now we know it's true. There's ethnic medicine that's out that genetically backs up the fact that there are various drugs that work differently on black patients. So this salt gene that many of us have, okay, this salt gene that we have makes us to have hypertension more. Well, you say, well, this is the common premise, and I'm gonna close with this. I know I'm talking, but I want you to go home with something that you're really, really gonna remember. Well, we used to eat this food when we were younger. Well, let me tell you what's different with that. You were out in the sun more. You worked more. You sweated more. So you were able to get this salt out of your body because you were out in the heat. If you're not doing that, this same thing that you eat as a delicacy is killing you. Okay? Because now special drugs are needed to get it out of your body. So this is called getting an understanding of knowing what it is that's driving it. And until patients, doctors, and others get to the point of understanding, we won't make much progress on that. But thank you. Thank you.
I'm going to be very brief. I just really would like to say that I am very overwhelmed by what I have seen on this campus over the last couple of days. I'm honored to have participated in this event. And you've seen me on my phone. I was not being rude. I've also been coordinating the medical response, making sure everyone had plenty of water. If anything happened, that everyone was taken care of. So that's what I've been doing here. But I just want to say thank you for your service. Thank you for what you did 50 years ago. And I hope that for those of us who have not yet accepted what we're supposed to be doing, I know that a long time ago I knew that I was going to engage in public health. And so I've done that for the last 20 years. And I hope that we take whatever talents that we have and do exactly what you guys did 50 years ago. Use it to make our entire existence, not just for one population, for everyone better. So thank you for that.
Thank you for staying. 6 o'clock, it's been a long day, and I appreciate the opportunity of being here. Thank you.
So please, let's give one more, like you care, round of applause for all those folks up there. Thank you, thank you.